Okie dokie. Right then, I'm just going to pull the questions up and start working through them. So, the first question that we had through was all around things like food and what somebody was eating and that kind of thing. So, what one of the questions was would they would like an explanation on the topic of food, so how food can really help with AKU and other things that people should or shouldn't be doing, which I know we had a whole chat about. We had the dietitian Claire at our session, but this particular person realised that all foods that contain grains also caused pain and that kind of thing. So, a bit more information on anything like that would be helpful, Ranga, if that's possible. Oh, I've just got someone else to let in. Sorry, bear with me. Yeah. Does that make sense, Ranga? Would you like me to read the paragraph?
I'm not a dietitian, but the great thing about dietitians is that they're very good at looking at what people actually eat and individualize the plan for people. That's what they're really good at, and I'm not going to be doing that.
Yeah, that's fine.
But
So,
I do have some very general, important issues to tell you about diet and AKU. Okay.
yes. Okay.
Um, if you really start with what alkaptonuria is, it's a problem with not being able to metabolize phenylalanine and tyrosine, which is there in protein. And normally, the protein we consume over the day is fully broken down during the day so that there's no carryover to the next day. And you can start fresh again because there's no way to store phenylalanine and tyrosine from day to day. So that then means it's important to think about how much protein one is eating. Okay. So we all need protein for normal life, okay, and to stay healthy. And it is assumed most of us on average eat about 1 gram per kilogram of body weight in terms of the protein intake per day. And if you start thinking about a condition like alkaptonuria and you want to decrease the amount of protein, then it is unsafe to go below 0.75 grams of protein per kilogram body weight. Okay, so the maximum you can do is 25% reduction in protein per day, because if you go below that, you won't get the critical protein to keep you healthy. Okay, you become malnourished and you actually become unwell. Okay, so the maximum you can do is 75%, 0.75 grams per kilogram body weight. Now, the difficulty with that is if you eat, even if you're fantastically compliant with the difficult diets that the dietitians will give you, and you're fully compliant, and you are only consuming 0.75 grams of protein per day, that is still giving you a vast excess of phenylalanine and tyrosine. Okay, it is still more than 10 times more phenylalanine and tyrosine than you need. Okay, so therefore you will still be making a lot of homogeneous acid inside the body. Remember, we are talking about alkaptonuria now. We're not necessarily talking about nitisinone and the tyrosine issues. We're talking about alkaptonuria itself. Okay, so therefore, diet doesn't work by itself in terms of dealing with alkaptonuria. Um, I might also say something about, because one of the questions I think in the email was the difference between animal protein and vegetable protein. Okay, so animal proteins are easier to digest. You can get 100% out of all the amino acids that you consume in terms of meat and animal protein. With vegetable, for example, legumes and grains, you can't digest it fully. Okay, it's only about 80 to 85% digestible. That means 15% of the protein is not digested. So in a way, that's like being on 15% protein restriction, okay, because you're not fully restricting. Um, so beyond that, I know some people write and say, oh, I did this and I avoided that and I was fantastic. I didn't have pain. I felt great. All that's fine. I mean, that's all individual. I mean, there's too many things happening in terms of pain and what what affects pain for all of us to make any generalizations about diet. So I'm not going to. Um, so, so that's about animal protein. All vegetable protein, animal protein also contain the same amino acids. So there's nothing magical about, eating a lot of vegetable protein, thinking that's somehow better than animal protein. But as I said, it's about the degree of digestibility. So maybe if you're eating more vegetable protein, you're on a more protein restricted diet than not. Okay. Um, Now, just to finish off the story of the diet and the effect on AKU, there are two things to think about when you're talking about pre-nitisinone. We're not talking about nitisinone now. So if you're thinking about alkaptonuria, you're thinking when you go on a low protein diet, why are you doing it? Are you doing it because you want to control symptoms? Or is it because you want to control the homogeneous acid levels? And they're very different. Okay. So you could have some decrease in homogeneous acid if you eat protein restricted meal, but it doesn't necessarily translate to symptoms. Okay. Um, and when we look at burden of disease, the amount of AKU people have, what we find in our research at the National Centre in Liverpool, as well as in the National Institute of Health, which was published in the New England Journal of Medicine, is that the people who say that they have been on a low protein diet, historically, we're talking about adults now, we don't find any difference in terms of the amount of AKU they have compared to people who haven't restricted protein. Okay, so I mean, there could be lots of reasons for that. One might be it's very hard to comply with low protein diets. I mean, we all know that. I mean, so um, so the problem there is it doesn't work. Okay, in terms of objective data, in terms of how severe the AKU is in patients, people who have been on a low protein diet don't seem to behave any differently as adults compared to those who have restricted. Okay, that's the first thing to say. The second thing is actually the opposite. Is it safe? Okay. Is it safe to do a low protein diet? Most patients, until recently, before AKU has become important, were managing their own protein restriction at home, unsupervised. And of course, I've seen some horror emails about mothers restricting children totally of protein in the diet and things like that, which is a complete no-no. So if you're going to go down the route of protein restriction, you have to be supervised. Especially for children, you need to make sure that they grow properly because the needs of proteins in children is much greater than adults. Okay. So the other thing that we found in terms of the safety side of it is mostly all adults who come to the National. I know there are a few people sitting here from the National Centre here. Hi, morning, Brenda. And I know that when most of the people that come to the National Centre are malnourished. Okay. And how do we know this? Because we do proper estimation of their nutritional state. We measure the muscle circumference in the arm. We measure skin fold thicknesses. There are loads of things we do. And based on that, we know that virtually all have a degree of malnutrition when they come to center. And this is bad news in the sense that if you're already malnourished when you come at baseline, then your ability to tolerate any stresses, for example, if you need a knee replacement or a hip replacement or something like that, then your basic health, the starting point is actually quite low because you're already malnourished and you're going to go for surgery. Okay, so there is a real problem there. And it is magnified to some extent by going on intestinal because we're reinforcing further restriction. We're saying continue the restriction in terms of the protein, but luckily it's all supervised. And one of the things we do is to try and make sure that people are healthy to be able to stand up to surgery and other things. So our dietitians are really important for us for these reasons. Okay. Um, I made a few points of which I wanted to bring out. I'm just having a look at that. Children, of course, are different because with children, I think there are a lot of important questions here about children and what to do in terms of diet for children. They must be supervised. If you're thinking of restricting dietary protein in children, they need to be supervised so that their growth curves are not affected, that they grow properly and have to be supervised by a dietitian. And that's really important. You shouldn't do that at home. Okay. Um, there are no good data in in any significant number of patients of children that have been um, tried long term on low protein diets. There's no such diet. There's no such publication out there. I know occasionally we see 3 patients published by somebody saying, oh, the urine homogeneous acid came down a little and so on. But there's absolutely nothing out there in terms of 40, 50 children being followed the low protein diet over X number of years or things like that. So there's nothing there. And the problem also is that at that stage, their symptoms are very minimal. And it's not possible to say what is the effectiveness of the diet. Okay. And children can't do 24-hour urine easily. So therefore, there are all sorts of practical issues there in terms of being able to assess whether low protein diets in children work or not. Okay. Um, I'm having a look at my little list here to see if I've forgotten to say anything. I know both Brendan and Juliet, who are fantastic scientists at the University of Liverpool here, and I know I've been trying to interest them in maybe doing a mouse study on AKU by restricting protein long term. But even that is quite challenging, isn't it? Because you can't restrict protein even in mice too much because they will die. Is that right, guys? Do you want to say something about that?
Yeah, I mean the benefit of our mouse model here in Liverpool is we can, we have much greater control over the environment and their intake. But even then, we are very limited by the strict Home Office rules here. We're not allowed to withdraw food at present on the current license that we use. So it is something that we're interested to look into amongst our other studies. So a lot of the work we're focusing on now is on this new inhibitor, which is designed to reduce tyrosine on nitisinone. So that's kind of our main focus, but we do have these other studies in the background as well. And, looking at the long-term effects of protein restriction is also one of them as well.
Yeah. And Ranga's right, we have to be careful that the mice don't lose weight and things like that, otherwise we can't keep them. So, but it's something we could look at.
Well, you should mention the mouse study that you carried out on the phenylene tyrosine free diet that you did for thalassemia, briefly.
Yeah, so we have used our AKU mice before. We can give them the drug nitisinone. We just put it in their drinking water and it makes their tyrosine go up, just like it would in patients with nitisinone. And we did a series of studies where we reduced the dietary intake of just phenylalanine and just tyrosine together. And Ranga's quite right, actually. We had to reduce the amount by quite a lot, which wouldn't be feasible, I don't think, Ranga, in patients necessarily. But we did show a really nice effect that when we reduced tyrosine and phenylalanine from the diet, the serum tyrosine did come down really, really nicely. But that was whilst we were maintaining normal protein intake at the same time. because we
that's
can
really,
specifically alter diets of mice.
yeah, that's nearly free, phenylalanine tarsin free, isn't it?
Yeah, with normal protein.
Almost zero phenylalanine tarsin, which is
Yeah,
simply impossible to do. And of course, you only did it for a week. You couldn't do it for longer than that, because
yeah,
otherwise your mice would probably have become ill and died.
yeah,
So,
exactly.
so the same issues are there, even in mice. But I think it'd be interesting to see whether low protein diets long term in mice, which still doesn't kill them off, has
Yeah.
any effect on AKU.
Yeah, I think we could look at the pigment Ranga in the
Yeah,
joints. Yeah,
but it's an expensive study and a difficult study to do.
yeah,
But we have, this is one of the things we have thought about, but we haven't done it yet. Yeah.
yeah.
Thank you guys. That's really, I'm soaking it all up myself. It's really interesting everything that you've explained. We have had a question in the chat about somebody that's come to the Liverpool Centre about using 2 or 10 milligrams of nitisinone. What are the benefits with 10 and what are the cons? And will I get blind easier? As in, like, the crystals in the eyes.
Yeah. Again, I think it's a clinical question, isn't it? I mean, I've written a paper looking at the, comparing 2 milligrams of nitisinone versus 10. And I'm very happy if that person makes themselves known. We can send you a copy of that paper so that you can have a look and read for yourself and see how we've done it. But essentially, 2 milligrams of nitisinone decreases homogeneous gas in the urine by 95%. And the 10 milligrams decreases by 99.7%. So you're quite right in asking, what is the advantage of only an extra 4% or so in terms of the homogeneous acid reduction, in terms of the effect on AKU? And the answer is, we found that the effect is quite big. Okay. And the effect is something like 4 times more. For example, if you're on 2 milligrams, you can slow down AKU compared to no treatment by about 20 years. Okay. This is assuming you start early. Now, if you start 10 milligrams at the same time, you can slow it down by 100 years. Okay. So it's because of the slope, the decrease in the disease burden with the 10 milligrams is much lower, and it adds up over time. So it delays the onset and delays the burden of disease by 4 times more, even though the decrease in homogeneous gas in the urine is only about 4 to 5%. What are the cons? Well, the cons are, you have to remember the 10 milligrams we did was in SONIA 2 clinical trial. And of course, all patients in the SONIA 2 clinical trial, there were 69 in the nitisinone group and there were 69 in the controls. And the 69 patients in the receiving nitisinone were simply given 10 milligrams of nitisinone straight away. Okay, and there was no dietary intervention. So they were started on 10 milligrams and sent away. Okay. And they did that for 4 years and came back. And of course, as we now know, 10 of the 69 patients went on to develop corneal keratopathy, which means it's like a conjunctivitis-like problem in the eye. So they are basically developed a red eye, pain in the eye, blurred vision, tearing, and redness of the eye. So that's what happened. And the earliest it came was about 6 weeks. And it can come on anytime if if you eat too much protein. Okay, because we want everybody to go a little bit easy on the protein intake without necessarily having a dietitian involved or doing anything about the diet more formally. And the good thing was all 10 patients, as soon as they told us they had the problem with the eye, we stopped the nitisinone, and of course the eye problem cleared up within 2 weeks. Okay, and they're completely back to normal. Okay, and then of course this also happens in clinical practice. When patients develop a problem, we stop the nitisinone and then give them a month or two for the eye to completely heal. And then they come back and see the dietitian so that they can tighten up on the diet and restart. Okay. If they've been on 10, they can go down to 5 or 2 or whatever. If they're on 2, they can go on to 2 milligrams every other day. We even have one patient who's taking 2 milligrams twice a week, okay, in the National Center. So it's all about managing the issue. So these are what we call, this doesn't happen often, by the way. People who get the eye problem doesn't happen often. But they are what we call in medical terms compromised patients, because they're compromised by the fact that their eyes are different. The metabolism of the eye is different from others, and therefore they need a different kind of approach for that. So we are looking forward to the day when we have some new novel treatments which will help us to deal with the tyrosine better without necessarily going down the route of the diet.
Thank you so much, Ranga. If you did want that paper sending to you, I think it was Robert who asked the question. Do let us know or let me know, and I'll get that off Ranga and email that to you afterwards. That's no problem. I'm just going to return to the list. Bear with. I'm just going to let somebody else in, guys. I won't be a moment.
Can I ask Ranga one more thing?
Of course, absolutely.
Yes, well, start early. I'm 75. So is it a good idea to start with 10, or is it better as good to continue with 2?
You're right. I think normally age is usually an important issue when we start thinking about drugs, okay? Because as we get older, the amount of body water decreases, and of course, nitisinone distributes into body water. So you can expect the effect to be slightly higher, but not significantly. But the way I would explain that is a lot of people in the National Center and in the clinical trial were over 60, 70 years of age. Okay, the average age was about 45, which means there were a lot of people who are in the older age range. We don't do anything different for the older group. So I don't think, if you're asking me, should you start lower because of the age, we are not doing that. For the simple reason that if you develop an eye problem, whether you're young or older, it's the same issue. And interestingly, when we look at the age of the people who develop the eye problem, they're all mostly young. Okay. And that suggests that maybe there's an element of not complying with the diet, that they like eating protein-rich foods, which if you're older and you're more mature, you can probably put up with a bit of restriction more easily than if you're younger. So
No.
before you.
So what do you suggest? Shall I ask my doctor to get 10 milligrams, or shall we stick to 2?
When we see patients, when we started the National Center, we had patients on 2 milligrams. So there's no 10 milligrams available at the time. So since this audit finished in 2019, this is an issue we are confronting, okay? Because we want to decide, should all patients go on 10, or how should we do it? So the way I do it, and the way we do it in the National Center, is we decide on patient by patient basis. If you have more severe disease, which is still symptomatic despite the 2 milligram dose, we think of a higher dose. You can go to 5, and if you're still having problems, you can go to 10. Okay, it's about need-based. And I also use the homogeneous gas level in the blood to guide me. If the levels are still detectable, the homogeneous acid, that means it might be worthwhile to try and get it down even lower by going on a higher dose. Okay. And of course, all our patients will need support in terms of the low protein diet to make sure the tyrosine doesn't go up. The difference in tyrosine between the 2 milligrams and 10 milligrams is minimal long term, because the body adapts, and there are things that the body is able to do metabolically that allows you to handle the tyrosine better over time. And over time, the difference between the 2 and 10 seems to vanish. So yeah, as I said, if you try the higher dose and you run into problems, you can always come back to the lower dose. So you don't need to it's not permanent. It's a flexible situation.
Okay, thanks a lot.
Thank you. And thanks for the great question as well, Robert. That's really helpful. I think it'd be helpful for others as well. So another question that we had was, does alkaptonuria affect your bones or just cartilage?
Yeah, I have a theory about this. I know our scientists are listening here carefully, and of course, one of my close collaborators is Professor Jim Gallagher. Of course, he's an expert in bone biology, and of course, his belief is it doesn't affect bone. Okay, so I don't know whether you know what bone is. Bone comprises of a lining called periosteum, which is the outer lining of the bone, and on the inside you have a lining called endosteum. Okay, and these can pigment. The periostea and the endostea can pigment, and we think that the bone itself doesn't pigment because there's a lot of calcium there. But I was doing a little bit of research this morning, Brendan and Juliet. There's something called the remodeling space. Okay, so about 10% of the bone per year is replaced. Okay. You find that hard to believe, isn't it? Over 5 to 10 years' time, virtually all of the bones that we have is completely recycled. Okay, we have new bone. So bone is not a tissue that once you have it, it doesn't regenerate. It changes around. Okay, it keeps cycling. And of course, when during this remodeling cycle, what happens is bone is broken down, and then new bone is formed. Okay, the new bone that's formed is then mineralized. So I'm thinking, Brendan and Juliet, we need to rethink this idea. So if you've got new bone forming and if it's 10%, there's no reason why it can't pigment. Okay, so as it stands, I have to say that we think the bone itself doesn't pigment, periosteum does, and the endosteum does as well. Now, so that's the pigmentation. Now let's think about the consequences of that. Okay, one of the things about affecting the bone is that the bone becomes thinner. Okay, if you get osteoporosis, then of course it can fracture. And I'm not going to name names here. There's someone here who's had fractures because of osteoporosis and things like that, and they've had lots of very fancy treatments to build the bone back up, and the fractures have gone basically. So the fracture issue is really important. That's what we're trying to prevent as well, because if and you can have fractures anyway. You can have long bone fractures. By that I mean you can have it in the hip, or you can have it in the humerus, or you can have it in the feet. And of course these are all very difficult to treat as well, especially in the feet. And of course we have to find a way of treating it these days. And of course we do things like the bisphosphonates, and the once a week pill called alendronate. And there are intravenous infusions, there's subcutaneous injections called denosumab. There are loads of things to do. And of course, there's something that builds new bone up called teriparatide and parathyroid hormone treatment. And there are other things as well now which have just come online in terms of building new bones of new bone as well. So, osteoporosis is a risk factor in AKU. And of course, one of the problems here is in women, it's also the time when the estrogens are gone because they become menopausal. And of course, it is not easy to differentiate the effects of menopause from AKU at that age. And in men, of course, men also get osteoporosis, especially as they get older. And again, I think one of the reasons for that, there's something called pain-induced osteoporosis. Okay, pain decreases testosterone secretion in the body. And of course, and this is now a well-recognized entity. So if you decrease testosterone in men, they get osteoporosis. It's like the menopause in men. Okay. And of course, we see that again in AKE because there is a lot of pain there. And of course, then we have a lot of patients who have low testosterone in our clinics. And of course, we also deal with them by giving them testosterone as well as treatment. And of course, I've used to believe before we had the nitisinone treatment, that HRT might be something that's worth thinking about as well for women, because until the menopause, they seem to do better, and then they worsen after the menopause. So it seems logical, therefore, to think a replacement might be a way to go there. Okay. I don't know whether Juliet and Brendan want to add anything to this debate on bone and AKU.
I've not got much else to add, Ranga, other than obviously that you see a little bit of osteoporosis in patients, but that's also age-related as well. Yeah, I don't have much else to add.
Yeah, same. It's well covered, Ranga.
Okay, brilliant. Well, I've got another couple of random ones, and then I've grouped together ones that are quite similar. So another one that we had was, are calcium deposits in the skin / breasts related to AKU?
The answer is probably not. Oh, having said that, I think, again, Juliet and Brendan probably have done this more than I. I think when you cut pigment, it seems to be quite rigid. And of course, I think initially we were wondering whether there was any calcium in it. But I think we've since decided that there's no calcium in it. Is that right?
I think the jury's still out on that one. I know one of our PhD students who's been looking at some kind of chemical studies on the pigment is looking into this idea that maybe there is a relationship between HGA and calcium. As far as I know, it's really understudied.
Yeah, well, one of the things
literature.
about the pigment is it binds things. I mean, for example, we know melanin binds, octanotic pigment is like melanin, it's melanin-like. And of course, we know melanin binds heavy metals and other things in there as well. So in theory, you can't rule it out. But if you're asking me, is calcification a problem in AK? The answer is probably not.
Thank you. That's great. So the remaining questions all sort of seem to center around tyrosine levels and trials and things like that. So the questions that we were asked were, this patient would love to hear more about the impact of high tyrosine levels on the brain,
Yeah.
and would it be best for me to just ask these one at
Yeah,
a
I'm happy to
time?
do
Yeah,
one by one.
that's
Yeah.
fine.
I think when we first started using nitisinone, we were very worried about this issue because nitisinone was already being used in another condition called hereditary thalassemia type 1 since 1991. And of course, we came to know when we started thinking about trialing nitisinone and using nitisinone in patients in 2011 that this issue of learning difficulties due to high tyrosine during nitisinone treatment was something we wanted to avoid. Okay, so we were worried about it at the time, and of course, this is the reason why we put down psychometric testing. In other words, all people who come to Liverpool National Centre have been having psychometric testing, which is a way of testing brain function right from the baseline. So they had a baseline test before starting nitisinone, and then they've had annual measurements of brain function testing, psychometric testing every year. So basically, it's like IQ tests every year. And what we found is we haven't found any deterioration in psychometry. If anything, we've seen IQ tests improve over time. Okay, so it doesn't go down. So the effect of the high tyrosine on the brain doesn't seem to be there in adults. Okay. Equally, some of you may know that there's a publication out now from Poland where they've shown that AKU patients, AKU children, before nitisinone, this is untreated nitisinone children, have learning difficulties. So they have problems with brain function. Okay, so that therefore looks like AKU homogenetic acid itself might be having an effect on the brain, but the tyrosine doesn't seem to be having an effect on making the brain function worse. Okay, there are all sorts of interesting theoretical ideas as to why this might be possible, but in practice, we don't see anything. If anything, as I said, it seems to improve.
Thank you. That's really helpful. The next one was, what are the next steps for tyrosine inhibiting drugs to be tested in a clinical trial, and how much funding would need to be raised?
I think maybe Brendan and Julia should start off, and I will come back on the clinical development later. Do you want to summarize where we are now?
Yeah, of course. Yeah, so we're still at the preclinical stage with this area of research. So there's still a few things we would like to test in our mouse model to really show that the approach works in tyrosinemia. It's really encouraging that there is one drug that's been identified, which we've been studying, which has a really positive effect in PKU. So that's currently in clinical trials. There's the phase 3 trial has either just started or is due to start early in 2025, and that's going to be a year-long trial of the inhibitor in PKU. We've shown in our research that the same drug should also work for tyrosinemia. The same target that it hits should have a beneficial effect on plasma and tissue tyrosine concentrations, which is good news. So the short answer is we're still some way off clinical trials. The company that we're working with on this drug wants to finish their program for PKU first before they start looking at other indications. So it's probably not going to be until 2026. And by that time, that gives us a chance to finish our work in our mouse model, and hopefully we can move on to clinical trials quickly thereafter. And in terms of the money that needs to be raised, it's something that we're looking at. It will be a substantial amount that's needed. We know that we can do most of the preclinical work in mice on current funds, but applying for funds is, something that we're constantly doing. We're looking at different ways of doing this with the AKU Society. So yeah, it will need funds, and it's something that we're onto.
Can I add something there? I think the tyrosine remains high in the blood because unlike homogenic acid, which likes to come out in the urine, which is why the urine goes black in AKU, because most of the homogenic acid is coming out in the urine. There's very little in the bloodstream. Okay, it's 1,000-fold lower in the blood compared to the urine. The opposite is true with tyrosine, because tyrosine is a nutrient. So the body likes to hang on to nutrients. It doesn't want to leak it out because you want to keep it within the body. So the kidney doesn't get rid of high tyrosine. It in fact contributes to the high tyrosine by being there. So we've tried a few different approaches. One of the things we tried was maybe to block to break down the tyrosine in the gut as you're eating the food. This is called tyrosine ammonia lyase. And of course, Brendan and Julia tried that. Unfortunately, it didn't work. Okay, so there's a company in California which came on board with the preparation, and of course, it didn't work. So they dropped it. And then, of course, we now have this drug called SLC6A19. Okay, this is the one that Brendan was talking about, which works really well in PKU, brings down the phenylalanine in PKU patients from 1,500 to about 400. Okay, that's amazing. Okay, to think about. And all it's doing, it's turning the tap on in the kidney, and the phenylalanine is coming out in the urine rather than being reabsorbed back. Okay, and Brendan is very he's not blowing his own trumpet. They've shown some very good data in terms of the same thing happening with tyrosinemia during nitisinone. It comes down really nicely. Okay, and so it's called SLC6A19. It's called JN170. Okay, so
I'll put it in the chat, Ranga. It's a slightly different name for the human version.
yeah, yeah, it might be a different one. So Brendan will put that in for you. So that works really well. So, and we know that mice are different from humans. So we think the effect of the SLC6A19 will be similar to the PKU in humans. I think it'll come down by again about 70%, 80%. Okay. And of course, Brendan has a theory as to why it doesn't come down 100%, because he thinks there are dipeptides and tripeptides rather than free tyrosine in there. And you need to prove that. I want to see you prove that, Brendan. So we're working on that. So in Liverpool, we're quite excited that we've got a treatment for tyrosinemia. And think about it. So if this works, then we will be able to give this medication along with nitisinone, and of course you are on nitisinone plus this new drug, and you can eat normally. Okay. So this is actually the counterpart of a condition called Hartnup disease. Hartnup was a family in the UK where the condition was recognized, where there was no SLC6A19 in that family. And what they found was that they were leaking phenylalanine tyrosine and these amino acids in the urine, but they were normal otherwise. Okay, so this is really why we're quite excited about these developments. We think, and of course it's not permanent, because if you can adjust the dose to have the desired effect in terms of bringing the tyrosine levels down.
I've just added the name of the drug in the chat there, and there's an article as well with some recent data. So the next things, I mentioned this in my talk back in Liverpool in November, but the next things we want to try is that we want to establish that the beneficial effect that we've seen on the tyrosine being brought down, we want to see whether that is sustained over a longer period. In mice, so far we've just done relatively short-term studies, so we want to see that there's no kind of time limit on the effect, and we also haven't modified the diet in mice in any way. So we also want to see that the same effect we see is also maintained when mice take on a protein load, in a similar way to when you guys eat a protein-rich meal. If we simulate this in mice, do we get a reduction in that spike of tyrosine that we would normally see in the bloodstream after a protein meal? Is that reduced in the same way when there's been a load of protein that's been taken in? So these are the things that are on our priority list this year, and we hope that will really improve our chances of securing larger funding for a clinical trial.
And of course, just to finish off, we're also thinking about mRNA treatments. Remember the COVID vaccine that came out? That was mRNA vaccine. So basically, that means if you give mRNA and put it into a cell, for example, the liver cell, the liver should make the protein. For example, here we want to give HGD mRNA. HGD is the enzyme that's defective in AKU. And of course, if you put that mRNA in the liver cell, hopefully it will make the HGD, normal HGD in the liver, which will then completely normalize the metabolism. So it will bring down the homogenic acid in AKU, and it will also not lead to any increase in tyrosine. So it's a perfect replacement. Okay, gene therapies are still very long away.
Thank you so much. So another question we had was, are we getting any further thoughts about screening newborns? And they went on to discuss heel pricks.
Yeah, I think they're not keen. The pediatricians are not keen. We've had a chat about this, and they're not keen about it, simply because there isn't. One of the criteria for newborn screening is that there must be a treatment available in that period. Okay, otherwise they won't approve it. And at the moment, there's no nitisinone treatment in children. And of course, I don't want to rehash all the discussions that we had in the workshop. Nitisinone in children is a bit more risky. You don't want to start too early because of the brain growth and things like that. And we probably want to start after the age of 7 when the brain growth is mostly complete. And therefore, if there isn't a treatment early on in children, then that's one of the criteria that you need to tick for heel screen. I personally think that it's a low priority. Okay. And the reason I say that is most mothers are very observant in seeing whether the clothes stain with due to homogeneous acid. The nappies will go either red or black. So you've got a ready-made test. So all you need is an observant mother, someone who doesn't dismiss things. So if you have that, then you don't need to prick the poor heel of the child. Of course, you're not going to do anything new because the child is being pricked anyway to do all the other things that are being tested on the heel prick. But yeah, I mean, I wouldn't necessarily worry about this. At the moment, the heel prick newborn screening is a non-starter. Of course, you can do the DNA test on the blood that they collect at the heel screen. But again, that's a problem because you might have not normal HGD on genetic testing, but it might be completely normal in terms of function. Okay, this is something what we call a benign mutation, a mutation that doesn't affect the activity of the enzyme. So again, the people who are into the newborn screen are aware of this problem. That genetic tests will need extra tests to do to confirm the other thing. The phenotype is the most important. When I say phenotype, I mean the urine homogeneous acid. Homogeneous acid is the key in AKU.
Brilliant, thank you. I'm suspecting this might be from somebody from outside of the UK, but this question is how often to check tyrosine and other labs and various body organ scans, and what are the signs and symptoms that should be monitored?
I think it depends on local practice, but at the very least, if you go on nitisinone, assuming this is about nitisinone treatment, so if you go on nitisinone, the minimum you need to have is supervision by a metabolic specialist in the hospital, okay, someone who knows about nitisinone treatment. You need to be able to check the tyrosine levels in the blood. And I think initially, I think you need to check it maybe after starting at 6 months, and then once a year after that will be enough. And importantly, I think it is good to be monitored by a dietetic specialist at least once a year. Okay. All the other tests, of course, are up to the local doctor. In the clinical trial, we did a whole host of things in terms of seeing how the AKU progressed. But in clinical practice, you probably don't need to do all of those things. Okay. So you need to, but once a year, they also need to look to see if there are any complications for AKU itself developing, and to be able to deal with that. Like for example, dealing with the pain issues, with analgesia, with neuromuscular blocks, if need be, thinking about what the time for joint replacement and things like that, if necessary. So you still need the regular annual visits and checkups, if you like, to anticipate what's happening. Of course, the heart as well, to see what's happening in terms of the heart. So these are important things that have to be monitored locally. This is why I said you need a metabolic specialist or a rheumatologist locally to follow you up once a year once you go on nitisinone.
Brilliant, thank you. I think we've probably got time for one more question. So this person's asking, they're curious about what has happened since 2019 around the research on LFS. Is osteoarthritis related to LSF, and has there been any research on osteoarthritis?
Juliet, do you want to say that? I don't understand what this term means in terms of, we are not doing osteoarthritis research ourselves, but we know that AKU can be considered one model of osteoarthritis, because at the end stage, a lot of our patients donate their joints to us once at the time of surgery. We go and collect the samples, bring it back to Liverpool. Of course, Juliet is now in charge of the program. And And we studied those to try and understand this better. And we now know that the AKU has long been considered one model of osteoarthritis. There are several others, but there's one model of osteoarthritis. I don't know whether you want to say anything about it.
Yeah, so we're definitely looking at the osteoarthritis associated with AKU in the labs. That's one of our priorities for our research, and we've got a PhD student looking at that now. Hannah, just in terms of the question, I'm not sure what the LSF is actually referring to. I Googled it as well, and I still wasn't sure. So
I did too.
that part. But yeah, we are looking at the osteoarthritis and how does the HGA that is in the body actually affect the joints, and what is the actual mechanism of an AKU joint becoming diseased, because we know that the pigment gets in there, but we don't really know how it causes the joint to sort of have osteoarthritis more accelerated than a normal individual. So it's something we're looking at. We're looking at it in the lab with cell culture models, and I'm also looking at it with mice. So we've got alkaptonuria mice, and we've also got some osteoarthritis mice as well, and we're looking at combining them together. So it's definitely something we're working on, and we're very keen to have a look at. And I think, as many of you know, in the UK, if you have got joints, many of you do let us know that you're having the joint replacement, and we're always keen to come and get them. I think we've got a few from people in the audience today in our freezers. Yeah, so we really encourage everyone to keep doing that if they can.
There are very few successful treatments for osteoarthritis. There's, in fact, no treatment for osteoarthritis.
Yeah.
But, for all the arthritis, I think rheumatoid arthritis has a good treatment. But other than that, AKU is the next. In terms of what are called degenerative arthritis, AKU is the only one which has got a treatment that changes the progression of arthritis. Okay. And I think we have lessons to learn here in terms of what we learn about arthritis process in AKU to see how much of that we can use to target osteoarthritis, and that's what we're working towards, and that's what scientists like Juliet and Brendan are working.
Yeah, definitely.
That's great. Thank you. We have had one more question in the chat. This is from Robert, and I don't know if we'll know about this because it's obviously it's in Sweden, but Robert's asking about something called Solodrone to strengthen bones and whether that's a good idea or not. I don't know if you guys can see that in the chat. Do you guys know about that?
Sorry, what's the question?
Is it zeledronate?
So, yeah, that was my loose example of trying to pronounce that word, but yes.
Treatment for osteoporosis. So the standard treatment for osteoporosis in the UK, the cheapest, because osteoporosis is very common. So if you give everybody intravenous, the country will go bankrupt. So you have to start with oral treatments once a week. And if that doesn't work, because some people have acid problems and they can't tolerate it, or the effect needs to be introduced into the body quickly, then you give intravenous zoledronate. Okay, it's very powerful. But of course, in some people, it causes what's called a flu-like reaction. Okay, and of course, that can be quite bad. And then you may need to do something else, like denosumab, which is a subcutaneous injection, and so on and so forth. I don't know what the question was in relation to zoledronate. We certainly use it in AKU-related osteoporosis and fractures. No question about it. We do use that. Okay, and as I said, I think it's fallback if people can't tolerate oral bisphosphonate, that's the alendronate that I was talking about. Yeah.
Thank you so much. So then we've got one more question. We'll finish on this one, if that's okay, guys. And this is, do you guys know if any country has any guidelines on nitisinone for AKU? So I'm assuming outside of the UK.
As I said, I think I've tried to simplify it by saying there are no official guidelines published, by the way. Maybe this is something a task awaiting me. And of course, the reason for not doing that is we're still learning things about it. So, as I said, the important thing is nitisinone, going on nitisinone, having tests before nitisinone, especially tyrosine, having a metabolic specialist involved, having a dietitian involved, Tyrosine being measured every 6 monthly at least, once a year monitoring for any complications and how the AKU disease is progressing, whatever your local disease protocols might be. Okay, it all depends on what your local health can afford. You maybe can't afford all the things we're doing in the National Centre because we're doing an awful lot and we're getting generous funding by the highly specialized services, NHS England, to do that. So it all depends on local practice, but these are the minimum: dietitian, metabolic specialist, serum tyrosine, slit lamp examination, annual visits. Okay, there's your guideline.
Brilliant, thank you. I just wanted to say thanks to everyone for coming today, and also to the team from Liverpool Ranga, Brendan and Juliet, for taking their time to come along and provide extra information, because I gathered from when we all met there was so many questions for you guys, and we just had such few such a short amount of time to get through them all. So I think this has definitely been really useful. Thank you, everybody. If there is anything after this that you think that popped up and you didn't get a chance to ask it, or you want us to think about, then do send me an email, and we're always here to try and help and advise you guys. It is difficult when you're outside the UK because obviously our knowledge and expertise is in this area, in this country. So, but we will always try to help you. I will get this recording I'll put it on YouTube. I'm not sure how to do that yet, but I will learn and I'll get it all to you, and I'll send it round to you all via a link as soon as I've done it. So I hope you guys have a great rest of the day, whatever time of the day it is for you all, and you know where we are. It's lovely to see so many of you as well.
Very much.
Well, happy
Thanks
New
a
Year.
lot, everybody.
Thanks a lot. Thanks a lot.
Thank you, everyone.
Thanks so much.
See you all.
Thank you.
Thank you.
Yeah.
Thank
Bye.
you all.
Bye,
Thanks.
guys. Bye.
Hi, Brenda.
Bye, everyone.
Thanks.
Yeah. Bye.